بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is the fourth part of your lecture, The Periodontal Pocket, presented by Professor Yehya Abdel Razak. The root surface wall of the periodontal pocket often undergoes changes that are significant because they may increase the periodontal infection, cause pain, and complicate periodontal treatment. The root cementum suffers either structural, chemical, or cytotoxic changes. Regarding the structural changes, they are found in the form of the presence of pathologic granules, areas of increased mineralization, areas of demineralization, and areas of cellular resorption. The presence of pathologic granules have been observed with optical and electron microscopy and may represent areas of collagen degeneration or areas where collagen fibrils have not been fully mineralized. Areas of increased mineralization, probably a result of an exchange on exposure of the oral cavity of minerals and organic components at the cementum-saliva interface. The hypermineralized zones are detectable by electron microscopy and are associated with increased perfection of the crystal structure and organic changes suggestive of subsurface cuticle. These zones have also been seen in microradiographic studies as a layer of 10 to 20 micrometer thick, with areas as thick as 50 micrometer. No decrease in mineralization was found in deeper areas, indicating that the increased mineralization does not come from adjacent areas. A loss or reduction in the cross-banding of collagen near the cementum surface and a subsurface condensation of organic material of exogenous origin have also been reported. The areas of demineralizations are suggestive of root caries. Exposure to oral fluids and bacterial plaque results in proteolysis of the embedded remnants of Chartis fibers. The cementum may be softened and may undergo fragmentation or capitation. Unlike enamel caries, the root surface caries tend to progress around rather than into the tooth. We have two types of caries. The first one is active root caries lesions, which appear as well-defined yellowish or light brown areas that are frequently covered by plaque and have a softened or leathery consistency on probing. The second type, which is inactive lesions, are well-defined darker lesions with a smooth surface and a harder consistency on probing. The dominant microorganisms in the root surface caries is Actinomyces viscosus, although its specific responsibility in the development of lesions has not been established. The tooth may not be painful, but exploration of the root surface reveals the presence of a defect, and penetration of the involved area with the probe causes pain. Involvement of the cementum is followed by bacterial penetration of the dentinal tubules, resulting in destruction of the dentine. In severe cases, large sections of necrotic cementum becomes detached from the tooth and separated from it by masses of bacteria. A prevalence rate study of root caries in 20 to 64-year-old individuals revealed that 42% had one or more root caries lesions, and that these lesions tended to increase with age. Caries of the roots may lead to pulpitis, sensitivity to sweets, and thermal changes, or severe pain. Pathologic exposure of the pulp occurs in severe cases, The root caries may be the cause of toothache in patients with periodontal disease and no evidence of coronal decay. Caries of cementum require special attention when the pocket is treated. The necrotic cementum must be removed by scaling and root planing until firm tooth surface is reached, even if this entails extension into the dentine. Areas of serial resorption of cementum and dentine are common in roots unexposed by periodontal disease. These areas are of no particular significance because they are symptom-free, and as long as the root is covered by the periodontal ligament, they are apt to undergo repair. However, if the root is exposed by progressive pocket formation before repair of such areas, these appear as isolated cavitations that penetrate into the dentine. These areas can be differentiated from caries of the cementum by their clear-cut outline and hard surface. They may be sources of considerable pain requiring the placement of restorations. Regarding the chemical changes, the mineral content of exposed cementum is increased. The following minerals are increased in diseased root surfaces: calcium, magnesium, phosphorus, and fluorides. The microhardness, however, remains unchanged. Exposed cementum may absorb calcium, phosphorus, and fluoride from its local environment, making possible development of a highly calcified layer that is resistant to decay. This ability of cementum to absorb substances from its environment may be harmful if the absorbed material are toxic. Regarding the cytotoxic changes, bacterial penetration into the cementum can be found as deep as the cemento-dentinal junction. In addition, bacterial products such as endotoxins have also been detected in the cementum wall of the periodontal pockets. When root fragments from teeth with periodontal disease are placed in tissue culture, they induce irreversible morphologic changes in the cells of the culture. Such changes are not produced by normal roots. Diseased root fragments also prevent the in vitro attachment of human gingival fibroblasts, whereas normal root surfaces allow the cells to attach freely. This is why when we root plane the root surface, we have to remove all the necrotic cementum because, as we said, fibroblasts do not attach to diseased cementum. When reimplanted in the oral mucosa of the patient, diseased root fragments induce an inflammatory response even if autoclaved. This is diagrammatic presentations of the surface morphology of the tooth wall of the periodontal pocket. As we see, first we have the layer of cementum covered by calculus, then the attached plaque, number 2, then a zone of unattached plaque that surround the attached plaque and extend apically to it. Number 4, we have a zone where the junctional epithelium is attached to the tooth. Then apical to the junctional epithelium, there may be a zone of semi-destroyed connective tissue fibers. The areas number 3, 4, and 5 are called plaque-free zone, which are seen in an extracted teeth. Periodontal destruction does not occur in all parts of the mouth at the same time, but rather on a few teeth at a time, or even only in some aspects of some teeth at any given time. This is referred to as site specificity of the periodontal disease. It is very common to find sites of periodontal destructions next to sites with little or no destruction. Therefore, the severity of periodontitis increases with, number one, the development of new disease sites and the increased breakdown of existing sites. The spread of infection from periodontal pockets may cause tissue changes in the dental pulp. Pulp changes may give rise to painful symptoms and adversely affect the response of the pulp to restorative procedures. Involvement of the pulp in periodontal disease occurs through either the apical foramen or the lateral canals in the root after infection spreads from the pocket through the periodontal ligaments. Atrophic and inflammatory changes occur in such cases. Normally, the distance between the apical end of the junctional epithelium and the alveolar bone is relatively constant, while the distance between the apical extent of calculus and the alveolar crest in human periodontal pockets is most constant, having a mean length of 1.97 mm. The distance from attached plaque to bone is never less than 0.5 mm and never more than 2.7 mm. These findings suggest that the bone resorbing activity induced by the bacteria is exerted within these distances. However, the finding of isolated bacteria or clumps of bacteria in the connective tissue and on the bone surface may modify these considerations. Pocket formation causes loss of attachment of the gingiva and denudation of the root surface. The severity of the attachment loss is generally but not always correlated with the depth of the pocket. This is because the degree of attachment loss depends on the location of the base of the pocket on the root surface. Attachment loss is measured by the distance between the cemento-enamel junction and the base of the pocket, while the pocket depth is the distance between the base of the pocket and the gingival margin. Pockets of the same depth may be associated with different degrees of attachment loss, and pockets of different depths may be associated with the same amount of attachment loss. The severity of bone loss is generally, but not always, correlated with the pocket depth. Extensive bone loss may be associated with shallow pockets, and slight bone loss can occur with deep pockets. This diagram represents different pocket depths with the same amount of attachment loss. As we see here, the arrows point to the bottom of the pocket, and the distance between the arrow and the cemento-enamel junctions remain the same despite the different pocket depths. This diagram represents the same pocket depth with different amounts of recession. In A, there is a gingival pocket with no recession. In B, a periodontal pocket of similar depth as in A, but in some degree of recession, with some degree of recession, while in C, the pocket depth is the same as in A and B, but with still more recession. The only accurate method of detecting and measuring periodontal pockets is careful exploration with a periodontal probe. We have to notice that pockets are not detected by radiographic examination. The periodontal pocket is a soft tissue change. Radiographs indicate areas of bone loss in which pockets may be suspected, but they do not show pocket presence or depth, and consequently They show no difference before and after pocket elimination unless bone has been modified. Gutta-percha points or calibrated silver points can be used with the radiograph to assist with determining the level of attachment of the periodontal pockets. They may be used effectively for individual pockets or in clinical research, but their routine use throughout the mouth would be difficult to manage. This photograph shows extrusion of the central incisor and diastema associated with periodontal pocket. The entire length of the periodontal probe is inserted, as we see in B, to the base of the periodontal pocket in the central incisor. This photograph shows probing of a deep periodontal pocket. We notice that the entire length of the periodontal probe is inserted to the base of the pocket in palatal surface of the first premolar. Periodontal pocket occurs when the disease causes the normal gingival sulcus to become deeper than normal. The normal gingival sulcus, as we know, is 3 mm or less. There are two different pocket depths. The first one is the biologic depth, and the second is the clinical probing. This diagram represents in A the biologic or histologic pocket depth. The biologic depth is the distance between the gingival margin and the base of the pocket. That is to say, the coronal end of the junction epithelium. These can be measured only in carefully prepared and adequately oriented histologic sections, while the probing pocket depth in B is the distance to which the probe penetrates into the pockets. Probe penetration can vary depending on the force of introduction, the shape and size of the probe tip, the direction of penetration, the resistance of the tissues, the convexity of the crown, and the degree of tissue inflammation. In healthy sulcus, the probe penetrated the epithelium to about 2/3 of its length, while in case of gingivitis, it stops 0.1 mm short to its apical end. In cases of periodontitis, the probe tip passed the most apical cells of the junction epithelium, 0.3 mm in the connective tissue. The probe should be inserted parallel to the vertical axis of the tooth and walked circumferentially around each tooth to detect the areas of the deepest penetration. To detect the interdental crater, the probe should be placed obliquely from facial and lingual surfaces. In multi-rooted teeth, furcation involvement should be carefully explored. This is a diagrammatic representation of osseous crater in a faciolingual section between two lower molars. In the left, we have a normal bone contour. In the right, this is the osseous crater. Vertical insertion of the probe may not detect the interdental craters. Oblique positioning of the probe, as we see in the right diagram, reaches the depth of the. Walking the probe is important to explore the entire pocket. Exploring with the periodontal probe in the left may not detect, as we see in the left, may not detect furcation involvement. Specially designed instruments known as neighbor's probe, as we see in the right, can enter the furcation. Pocket reduction surgeries are aimed at reducing the probing pocket depth in patients with periodontitis. Depending on the disease presentation, one can take either resective or regenerative approach. In case of suprabony pockets, they are primarily treated by resective procedures such as gingivectomy or osseous surgery, whereas in intra or intrabony defects with multiple walls that are contained, they are generally treated using regenerative approaches. Upon completion of this lecture, the student should be able to define the periodontal pockets, classify different types of periodontal pockets, recognize their clinical features, discuss the pathogenesis, describe the histological findings, and associate between the clinical features and the histological findings. He should illustrate periodontal disease activity, clarify site specificity, predict pulp changes associated with periodontal pockets, and identify the relation of bone loss and attachment loss to pocket depth, and review the differences between suprabony and intrabony pockets. Your reference book is any edition of the Carranza's Clinical Periodontology, either the 11th edition, chapter 13, page 127, or Carranza's Clinical Periodontology, the 12th edition, chapter 20, page 277, or the 13th edition, chapter 23, page 303. Finally, I would like to thank you, our dear students, with all my best wishes, Professor Yehya Abdel Razak.